Hello, I'm Dr. Melissa Walton-Shirley, and thank you so much for joining us today on theheart.org. We have with us today Dr. Jorge Plutzky, and thank you so much. I'm really anxious to talk with you. He has a special interest in diabetes and its impact on cardiovascular disease. So we'll just get right into it. I'd like to ask you, do we need to redefine the definition of diabetes? And I want to make, by way of introduction, a case for a patient that I saw on rounds one weekend who was around 48 years of age. He was a basketball coach, very active. He had a father who had had advanced cardiovascular disease much later in life and seemingly no other risk factors. His fasting blood sugar was around 80, and even though it wasn't planned for the day, I gave him 75 grams of glucola, and at the second hour he was 240. So what happens with those patients, we discussed earlier, is that most usually they're sent home to their family physicians, who often tell them that's really not a big deal, you're borderline diabetic. So can you speak to that issue?
Sure. Well, it's a fascinating one, and even the cardiovascular trials have pushed us to think about, well, how do we define diabetes? Because we've defined it traditionally by glucose levels, and yet the real clinical outcomes are often cardiovascular in nature. And so what is diabetes becomes a very interesting, almost philosophic question. And I think that really our methods of trying to make that diagnosis look to uncover abnormalities in metabolism. And you can do that because someone's glucose levels are staying high all the time, and as a result their A1C is high. But in fact, there have been studies like the DECODE study that suggested if you look at someone's ability to respond to the dynamic challenge of a meal, like a glucola that you gave to this patient, you can uncover people who really pathophysiologically are either diabetic or, as we now refer to, pre-diabetic, because they couldn't handle the glucose load normally, which is just what your patient did. And the vast majority of our patients spend most of their time in a fed postprandial state, especially, Western lifestyles. But we will try and make the diagnosis of diabetes after a 12-hour fast, where early in the earlier stages of the disease, they may be able to mount a normal fasting glucose, but throughout the course of the day, they're having an abnormal glucose or lipid response and never really clearing their glucose in the same way. It could mean their vasculature is being exposed to hyperglycemia for many hours over the course of the day. So I think the ADA, which is an excellent resource for this, would point to several ways that one can make a diagnosis of diabetes on an A1C, on an elevated abnormal fasting glucose, a random glucose that is even more elevated, or in the form of an oral glucose tolerance test, all of which can allow you to say that the patient has diabetes. But the other issue that comes with that is that now what do you do? What do you do in this gentleman's case? Certainly an A1C might be helpful. ADA is now supporting A1Cs for diagnostic purposes. But this really may be the early phases of disease in that patient, and it could be that you could improve things with diet and exercise, depending on his weight. Even as a basketball coach, there's overweight basketball coaches. It wouldn't be that necessarily that patient would go on to drug therapy, because one of the issues with some of those drug therapies is they can cause hypoglycemia, especially in earlier phases. Some of the drugs, however, don't cause hypoglycemia, and it's a very intriguing question of when should we initiate therapy, how early should we initiate it, can we reverse some components of diabetes in the early phases? And these are things still under active study. Like even now here at the ACC, we've seen the bariatric surgery study that showed that people with diabetes could be, when they lost weight, reversed in terms of their disease process. So there are many ways to rise the diagnosis. You used one, and I actually encourage docs to use the oral glucose tolerance test when you have a suspicion something else might be going on. Another very good thing to think about is when you see high trigs, is ask yourself, does this patient have diabetes?
So what exactly is a normal postprandial glucose? Because on some of my laboratory parameters, they make the reference range of anything less than 140.
Right.
But I have to confess, I don't cut much slack for folks that hit 147.
Mm-hmm.
I have a conversation with them about diet, restriction of carbohydrates, etc. So what is your definition of an abnormal postprandial?
I think using your local labs, reference points is really is a very useful approach, and in that 140 range can tell you that this is a person who's not clearing normally. And in this patient's case, I'm just as concerned about who they're going to be I'm just as concerned what I'm going to do today for them as what we're going to do and who they're going to be in 5 years, 10 years down the road. This really may be a window of opportunity, especially in the obese patient, the sedentary patient, to really try and make even modest adjustments can often have a big impact. So I would look to any abnormal signal within your own parameters of your own laboratory, but usually it's in that 140 range. A lot of times you'll see the 200, 240 range, and you say, well, this is someone who's clearly not handling glucose in a normal way.
And then how do you treat the patient differently who has a super high triglyceride level that may have a postprandial level of 190 versus the person that has an abnormal postprandial but their triglycerides are okay? I mean, do you believe in fibrate therapy with statin? How do you approach that patient?
Well, the postprandial issue is an interesting one because just like we talked about a dynamic challenge with glucose, and that being more reflective, there are studies that suggest that postprandial hypertriglyceridemia may be more predictive than the kind of triglycerides someone can generate after a fast. I think in a lipid clinic scenario, we're often getting referred patients who have a very good LDL and are tolerating their statin, but in the presence or absence of a coronary disease have a significantly elevated triglyceride, which often travels with a very low HDL, and what to do about them. And the database for that is quite complicated and has been the subject of a lot of discussion. I think the first thing you have to do for those patients is really run through that list of secondary causes of high trigs. And it's something that almost all of us learn for board exams, but you really need to run through it on those patients to check their thyroid, check their urine analysis. Do they have nephrotic syndrome? Do they have diabetes? Is the diabetes not being well treated? Because that will improve the triglycerides. Is their diet really off? Too much carbohydrates often? Are they just incredibly sedentary? Are they drinking too much? All those can drive a triglyceride. If you run that list and make some changes around those, often the numbers will get better. A particularly important one is a reaction to certain drugs, like very high doses of thiazides can drive an elevated triglyceride level, or if the patient's on a retinoid, can often cause it as well. And beyond that, what we've looked to is the data with VA HIT that found with gemfibrozol a benefit in coronary disease with no statin therapy. And then in the subsequent triglyceride trials, the real disappointment has been that they really haven't done a trial with the classic American hypertriglyceridemia, trigs in the 300 range, 400 range, and low HDL. That's the subgroup in the big trials that seems to get the benefit. But many of those trials were done with people with triglycerides in the 160 range, and those people will not get a fibrate added in our clinic setting. We'll really aggressively go after secondary causes, do lifestyle things, and then the patient with significant risk will think about adjunctive therapy based on the subgroup analysis and wishing we had more definitive evidence. Fish oil, of course, is another alternative for treating triglycerides as well. So you really have to do it on a case-by-case basis and really not forget these secondary causes and lifestyle issues, but in a subset of patients, we will think about fibrate therapy.
What do you think about the patient that has high triglycerides who's a moderate alcohol utilizer? Do you then recommend complete abstinence from alcohol, or how do you handle that conversation?
Well, yeah, it's it's an interesting one to have. In the first phases, we really try and reset things, and we have evidence that modest alcohol intake can be beneficial in terms of cardiovascular events. If the patient doesn't have an issue with alcohol, we really try and get back to sort of a phase 0 scenario of what can we do across the board to normalize the triglyceride values. And if we don't, and if those numbers now normalize, and the patient didn't have an issue with alcohol, the intake of alcohol wasn't too considerable, then we would look to add it back in a modest amount. And often in patients they can tolerate alcohol. The alcohol wasn't the driver. But in that first phase, we'll say, let's go here a month or two with no alcohol. One of the things our patients forget is that alcohol, also carries significant calories.
Oh, absolutely.
And so part of this can be also trying to decrease their weight. And it's really striking when you pay attention to these issues how much better people's numbers get with very modest amounts of weight loss. And so as part of that resetting, we say, can we get you back here in 2 to 3 months, recheck your numbers, and then revisit whether or not we can reintroduce alcohol. Because if we recommend things to patients that they're not going to do, that really disrupt their lifestyle, then the chances of having them continuing to have normal triglycerides down the road because we're asking them to be completely abstinent is probably not going to work. So we try and work within the construct of a given patient, assuming that there's not alcoholism and increased LFTs and other issues, because alcohol can obviously be a very deadly issue as well. Oh,
sure. Now, correct me if I'm wrong, but I think Americans are a bit more lax about hemoglobin A1C than our European counterparts. I'm amazed when patients come into my office and they've been told their hemoglobin A1C is 6.5 and they're thrilled to death. It's so good.
Right, yeah.
When my European friends, they would rather see a hemoglobin A1C of 5.7 and actually try to have conversations about that goal with the patient. What's a normal or optimal hemoglobin A1C from your perspective?
Well, following ADA guidelines, less than 5.8 is normal, and that 5.8 to 6.4 range can be called pre-diabetic, and 6.5 and greater is diabetes. I think finding patients who have abnormal A1C numbers can be very helpful in terms of thinking about what can be modified to improve their overall metabolism and decrease their cardiovascular risk. And thinking about those patients, we still haven't resolved about how to treat them on the diabetes front. Should those patients go on metformin? Well, the diabetes prevention program says that more metformin will have a benefit in their conversion to diabetes. The critics would say, but you're just giving them an antidiabetic drug. We've had similar data for other medicines as well. So that's not been well resolved. Some patients want to be aggressive and they'll go onto the metformin early, even though they haven't crossed the threshold for diabetes, under the notion that maybe this would have long-term benefits on how many drugs they'll need to be on for their diabetes. Maybe it'll have benefits on cardiovascular events. Maybe over the long term, we haven't seen that in a study, that there would be other benefits from early intervention. Lifestyle will definitely improve those people. We saw that in the diabetes prevention program as well. But I think these are very good patients to also look at carefully for their blood pressure and early intervention on increased blood pressure, and to think about their LDL and the appropriate LDL target for those patients who you think are at very high risk of converting to having diabetes. So I would use it as a marker of saying you're on a track here that is going to potentially lead into lots of issues and lots of complications, and what can we do now to focus on that. I found it to be quite effective to point out to patients that they have an abnormal A1C.
You're a trialist, so what's the latest data on how we should be treating our diabetic patients and how it's a large driver of cardiovascular instability? What's the latest information, and what do you hope to see change about the way we design our trials when we study diabetics?
Well, unfortunately, it's been a very complicated issue. We've really gone after this hard, and we've seen pretty clear-cut improvements in microvascular disease, which shouldn't be diminished, in retinopathy, nephropathy, neuropathy, as we improve glucose control, but really not good definitive evidence of an improvement in macrovascular disease despite major efforts now with a ACCORD, ADVANCE, and VADT, 3 landmark trials that didn't show an improvement, and actually in ACCORD showed an increased mortality, raising lots of issues for us in terms of thinking about this. So I think that the take-home message from those studies is that A1C is important, that we've seen some reaction the other direction where people say, I'm going to ignore A1C, and I don't think that's a good idea. Patients need treatment. In patients at high risk for the risky cardiovascular issue of hypoglycemia, like the elderly, people on insulin, that you certainly don't want to be driving down to try and normalize their A1C with really aggressive therapies, because the hypoglycemia may be as risky as anything else. And so a more moderate approach can be reasonable, but in someone who's in the earlier phases of disease, that may be a scenario where they're going to do better and that you can try and control their A1C. I really think we're left now with diabetes of looking to the idea that maybe there still could be drugs out there that could have benefit, and we see a lot of trials underway. There's a huge number of patients in cardiovascular trials looking at antidiabetic drugs, a whole host of them. And it'll be very interesting to see the outcomes of those studies. Some of those studies are oriented towards safety because the FDA has set safety hurdles for new drugs, and some of them are oriented towards benefit. But we have coming down the road a slew of trials with large cardiovascular trials with DPP-4 inhibitors, which work through changing the incretin axis by increasing levels of GLP-1, a gut hormone. We have trials of GLP-1 agonists, which are injectable and are already approved, that can often lead to weight loss and may have benefit or being studied for their cardiovascular effects. We have a dual PPAR alpha gamma agonist that lowers trigs, raises HDL, but also insulin sensitizes, being studied in ACS. We have other novel therapies of antidiabetic agents that are ongoing trials, and I think maybe that at the moment that's really where we have to focus while continuing to address other risk factors in these patients, making sure their blood pressure is under control, that they have the right LDL level, that where appropriate aspirin's being used, and that we're also trying to make sure these patients are being a little bit as active as they can be and watching how they eat. It really does matter.
Just a quick question about bariatric surgery.
Yeah.
When do you jump off and say, I've done everything I can do, you need to go have bariatric surgery, and then what can the patient hope to gain from an impact on their risk?
Yeah, well, so we've just had a publication of 2 studies that suggested, in small studies, but suggested in patients with diabetes and established diabetes that bariatric surgery could put a significant percentage of those patients into remission, where the diabetes would go away. It raises all kinds of issues. I think at the moment we really want to not get ahead of ourselves and really reserve those therapies for, as you say, patients who are refractory and really have morbid obesity. There's so many medical complications of obesity that we really stand to really help those patients by inducing significant weight loss. And so for patients with morbid obesity who have truly failed, I think it can be a very reasonable alternative. But I think it also, these studies that show this change in diabetes with bariatric surgery are really also telling us that we have to invest more time in thinking about medical therapies for obesity and better ways of implementing lifestyle changes, because there are some patients who can respond to that, especially in more specialized clinics where people have expertise. And instead of asking the busy primary care physician, internist, family practitioner to try and master how to achieve weight loss, you really need to be able to refer to a specialist who can achieve benefit. And we also need to keep looking for new ways to tackle obesity. We've just had the FDA look at a whole group of new drugs for obesity, and none of them passed until just recently. One in a second review was approved, at least by the advisory council. We'll see what the FDA does with it. So I think these bariatric studies are really pointing us to the need to come up with other therapies, and I don't think surgery is going to be an answer for the millions of Americans with obesity. I mean, it will very soon be 1 in 10 with overweight or obesity, and surgery is not going to be the answer for that. We have to come up with other strategies, but we're seeing what can be the benefit with significant weight loss.
Sure. I mean, we're always looking for the biggest loser so they can really be the biggest winner.
Yes.
After all.
Yeah.
Well, thank you, Dr. Plutzky.
Sure.
Really appreciate the conversation, enjoyed it, and we hope you enjoyed it as well. Thanks for joining us today on theheart.org.